Goal-directed hemodynamic management via transesophageal echocardiography in percutaneous hepatic perfusion procedure for uveal melanoma. This is not a common procedure, but it's gaining more popularity across the country. Percutaneous hepatic perfusion, or PHP, with melphalan is a targeted high-dose chemotherapy for the management of unresectable liver metastases that originates from uveal melanoma. This procedure is performed by an interventional radiologist and under general anesthesia. First, a left-sided triple lumen catheter will be placed in the IJ. That will be available for the anesthesia provider for any kind of infusion or any kind of transfusion that might be needed. Then the interventional radiologist will place a right IJ catheter, and that's for the inflow from the bypass line. Following that, he will place a right femoral vein access, and that will serve as the outflow between the two balloons that can be inflated between the hepatic veins. So any outflow from the liver will get sucked into those catheters and go straight into the charcoal filter system, and then back to the right IJ into the patient. On the left side, he will have access to the femoral artery, and that's the access point to thread a catheter all the way up to the hepatic artery, and that's where the melphalan is being infused. So the chemo agent stays mainly in the liver unless there's a leakage, and it can be straight drained into the filter system, filtered out, and blood without significant melphalan levels can get returned to the patient. And that will avoid having any systematic effects and consequences and complications from it. The anesthesia provider will also have access to the left-sided femoral artery blood pressure monitoring, and that's usually where the arterial blood pressure is being measured. So in this case, we outline the challenges and management of complications that's associated with the PHP procedure, and particularly hemodynamic changes that we see. A 46-year-old female with a history of choroidal malignant melanoma and with hepatic metastases was admitted for the PHP procedure, and we identified 4 episodes of hypotension during the procedure. We used a transesophageal echocardiography to identify the cause and to optimize cardiovascular function and to minimize the vasopressor use. So those are the 4 stages of hypotension we observed, and we labeled them as T1, T2, T3, and T4 based on the time it occurred. T1 was at the initiation of the veno-venous bypass, and there was a notable drop in preload and the cardiac output. The baseline cardiac output was about 4 liters, and once the bypass was opened, it dropped to 1.1 liter. That's about 75% drop. It was corrected, or the blood pressure was corrected with vasopressor support, but the cardiac output remained low until the discontinuation of the bypass. T2, we noticed another episode of hypotension. We also noticed on the echo there was bradycardia and myocardial dysfunction compared to the baseline that was observed during the IVC occlusion phase. And we saw a reduction on the right ventricle. The TAPSE went from 3 to 2 centimeters. The third episode of hypotension occurred with the opening of the charcoal filter, and more so with the second filter than the first one. And profound hypotension occurred. It necessitated the escalation of epinephrine and vasopressin doses. The patient was on an infusion, but also required multiple boluses. The cardiac output remained low at 1.4 liters a minute. T4, about 10 minutes after the second filter was engaged, the patient experienced an unanticipated episode of unstable bradycardia and hypotension. This graph shows the left ventricle end diastolic volume throughout the case. We can see from baseline it drops significantly to the bypass opening. Then we resuscitate the patient. We have an increase in the left ventricle end diastolic volume just before the filter opening. Once the filter is opened, it drops again significantly, and then it slowly recovers. And at the end of the bypass, we can see it returns almost back base to normal. This is the cardiac output that's been calculated based on the echo, and this shows a very similar graph. We can see the baseline at about 4 liters. It drops significantly up in bypass opening. Then we resuscitate the patient with fluid. It goes back to nearly a normal level, but that's very temporarily. Once the filters are opened, it drops again, and it recovers at the end of the case once the bypass is discontinued. This table shows us the data throughout the case. We recorded the findings on the TE and the medication that we used. Vasopressin was given at the bypass initiation phase. It was an infusion, and it needed to be escalated throughout the case. Same with epinephrine. Patient was started on an infusion at the IVC occlusion phase. Throughout the case, the patient received ephedrine and atropine boluses. One critical incident on T4, we can see here right or 10 minutes after the filter 2 was opened, and we saw a systolic blood pressure of 50, diastolic of 30, and a heart rate of 32. Significant bradycardia, ventricle function was slightly decreased, but no isolated areas of wall motion abnormalities. And the patient recovered after giving atropine, ephedrine, and epinephrine as a bolus of 32 units, so a significant amount. This slide shows the function of the heart based on the TE. This is the 4-chamber view, and we can see all the ventricles are functioning normally. This video is at the time of the IVC occlusion, and we can see there's significant reduction in the right ventricle volume and the left ventricle volume. We can see the ventricles are touching each other. This slide is before the filter 1 was opened, and we resuscitated the patient. So the ventricles are filled again, and we can see contractility is slightly decreased, but overall normal. This image shows us the video when the filter 1 was opened. Just ignore the writing on the image itself. That's not correct. We can see bradycardia. The ventricles are still contracting, and the volume seems to be adequate. So filter 2 opening is the most critical phase throughout the case. That's the time when the most significant hypotension will occur. We used to raise the blood pressure artificially with vasopressor support to about 180 to 190 systolic, and we would still see a drop in the systolic to about 70 to 80 systolic. And that's despite ongoing vasopressor support with boluses of epinephrine, vasopressin, no epinephrine. Starting to overcome the deficiency in preload, the amount of pressor use went down. However, we still use a good amount of infusion with epinephrine, in this case vasopressin, and bolus on top of that. And we think at this phase, the filter overall filters out all the catecholamine and any other substances that are important for vasoconstriction and to maintain hemodynamics. And that's probably why the patient is getting significantly hypotensive. This is T4 bradycardia 10 minutes after filter 2 opening. And this was a little bit unexpected, and we have not seen this in any other case before. But we also do not place a T routinely in those cases. I think it's important, since we have some incidents where someone can get significantly hypotensive and it requires early recognition and treatment, so a T can be very, very helpful in those cases. This is off bypass. We can see the heart is full again, and it's starting to beat, and the heart rate is picking up. So the unanticipated episode of unstable bradycardia and hypotension, we are trying to figure out the mechanism, and one thought is maybe it was a reverse vein bridge reflex, where the decreased venous return leading to reduced right atrial filling, decreased contractility, and a reflex bradycardia. However, this is not very clear because based on the echo, the right atrium does not look very underfilled. So this is still subject to exploration. So the charcoal filter is probably one of the main reasons why the patient gets very hypotensive. And the question is, what is being filtered out and how much is being filtered out? RBCs, coagulation factors, platelets, melphalan, of course, and how much, and whether it also filters out catecholamine and any other hormones. And charcoal is a non-specific filter system, so it can filter out almost anything that's circulating through the blood. We identified 4 distinct stages of hypotension during the PHP procedure. And the first one was the initiation of the bypass. The second one was the IVC occlusion. The third one was the charcoal filter opening, especially the second one, and 1 random episode. So the primary cause of the decreased preload is predominantly attributed to the limited bypass flow, and the max bypass flow for those procedures are 700 cc a minute. And considering the patient's baseline cardiac output was around 4.5 liters, that's about 1/6 of the patient's normal cardiac output. And since we cannot increase that flow, the patient will remain hypotensive based on the lack of preload. We also saw some myocardial contractility changes. So early cardiac monitoring via TE can provide critical insights and can facilitate goal-directed interruptive hemodynamic management and enable timely intervention to prevent adverse outcomes. And I think this is also a very good tool to titrate the vasopressor use, to cut down on the use, and maybe limit it to 1 or 2 instead of 3 or 4.